Excellent. Well, like Fiona, I'd like to also thank the incredible participants who have participated in my research. So my research is based on over 10 to 15 years of data that we have been collecting here at Frontier. So if you're part of that collection of data, I want to personally thank you. Now, preparing for this talk was actually quite tricky, as I realised I'm talking to a range of caregivers, some whose loved one may have been recently diagnosed with primary progressive aphasia, and for others where you've been on this PPA journey for quite some time. And so I'll try, for some of you, the information I'll be presenting will be quite common knowledge, but for others, this will be new information. And so it will raise some questions for you. I'll try to balance those two needs, but know that I'm very available after the presentation to talk to you, and I'm more than happy to correspond by email. So by this stage of today, we should be aware that primary progressive aphasia, it refers to a family of neurodegenerative disorders that are characterized by a progressive decline in speech and language skills. Hopefully also by now, we should be aware that there are in fact three main subtypes, and that these can be differentiated according to the presence or the absence of certain speech and language deficits. Now, given that the language deficits are the main complaint in this syndrome, and also given that the classification guidelines or the diagnostic criteria for this was only recently revised back in 2011, a lot of the emphasis has been on understanding the language profiles. Christian would be someone who has spent his whole career on doing just that. But we also know that these language profiles, they occur because of distinct patterns of brain atrophy and also distinct underlying neuropathology. And so we might expect that these distinct brain changes might affect things beyond language, such as cognition, behavior, and things like functional capacity, which when I refer to this, I'm speaking of the ability to live independently at home and within the community. And so for the past few years, I've been researching these topics. So with a background in neuropsychology, one test which does a great job of appreciating, understanding, measuring, let's say like an overall global index of cognition is the Addenbrooke's cognitive examination, or the ACE-3, as we call it. For our participants at the Frontier Clinic, they complete this test at every single visit to our clinic. So we have quite a lot of data on this particular test. I'm not going to go into detail about the test itself, other than saying that it's commonly used in hospital and tertiary specialist clinics, and it is incorporates the 5 cognitive subdomains. So there are the subdomain attention, memory, verbal fluency, language, visuospatial, and if you're a quick mathematician, you would have worked out that the sum of these subdomain scores can be summed to provide that overall global cognition score. So firstly, I wanted to show you how performance on the verbal fluency subdomain might differ across our primary progressive aphasia variants across them and over time. So there's a little bit going on here, so I'll try and break this down a bit. So verbal fluency, the way I like to describe it is it's this ability to generate words under time constraint. It's almost like a proxy or an index of how fluently one can speak in a flowing conversation. And once understanding this, it would be no surprise to us to see that for our patients who have these language problems, that the performance at the first time that they come to our clinic is impaired, but that performances at that first visit is equivalent or is about the same for each group. Over time, however, we are seeing that logopenic variant are showing increasing difficulties over time. As I'll explain in a little bit more detail later, this is a collection of data of 147 patients. Now, while I'm convinced that this is the best modeled graph, so this is the best way that I can represent our patient data to understand it across groups, it doesn't really reflect the personal experience. And so this graph may not resonate with your personal story. Another thing to mention at this point is that this graph, it doesn't also appreciate people who may be seeking intervention services such as speech pathology and speech therapy. I'm not sure what the graph would look like, but I just want to be frank or honest with that. Okay, so now that you understand what language might look like, what can we think about with these other subdomains such as, memory, attention, and visuospatial function? So memory on the ACE, it's tested in many ways. For example, we ask people to learn a name and an address, and then we ask them to recall that name and address later. We also ask about various politicians from the past and present, amongst other aspects of memory. One thing to acknowledge here is that the ACE, it measures memory using verbal content. So that we measure that the verbal information comes in, and we are asking our participants to provide responses verbally. And so we might expect language contamination to be occurring in our groups. That said, I think we can agree that over and above this language problem, we are seeing, if we concentrate on that logopenic variant, that they are experiencing difficulties with memory at the first visit, and that this becomes increasingly more difficult over time. By contrast, while we do acknowledge decline in memory skills for the non-fluent variant, we can see that, relative to the other two groups, this is holding up a lot better. The story for the semantic variant is a bit complicated, as we know from other research that they actually do quite a good job at retaining non-verbal information. So this is information that doesn't involve verbal or language content. But we know that when they are trying to learn and recall information that involves verbal content, that they appreciate, or they start to have difficulties. And of course, this would be a complaint amongst our caregivers that our person with the semantic dementia is experiencing problems with memory, but it does seem to be circumscribed to language, as we can see here in this graph. Another skill which is closely related to memory is attention. And so attention in this measured here is doing things like simple arithmetic and learning a short set of words. It must also be acknowledged here that we also measure the ability to remember where orientation to time and to place. So knowing where someone is and what the day is. So really, I think that title should be attention and orientation. That said, for the purposes of this talk, the way I like to differentiate episodic memory from attention is memory, it's that ability to remember what you did yesterday, what you did earlier today, or even, if you were to go to the supermarket and you were to remember what those set number of shopping items that you needed to recall. Attention, on the other hand, it's more to do with holding and updating information in mind there and then in the current moment. So we might think about if you were to ask someone to hang out the washing before you take out the rubbish. Of course, there's sort of two competing commands, and you need to kind of hold those two thoughts in mind until you can sort of can drop them after the task is finished. Or another example would be watching a movie. So being aware and following the plot of the different characters within the movie. But of course, memory, or that episodic memory, would be a couple of hours later, maybe the next day, remembering that you did see that movie. Okay, I've stressed that point. So we see here at baseline, we've got performances that are up close to the 100 mark. I should also clarify here that good scores would be around that 95 to 100 mark. So we are seeing, some relatively good performances. But yeah, unfortunately, again, with our logopenic patients, we are seeing a decline in this skill. For the other groups, they're holding up a lot better relative to that logopenic group. Finally, when we look at visuospatial performance, so this is the ability to make sense of visual information in the world and also interacting with it to some extent. We do see differences across the groups, but I think a main story I want to get out of this one is that actually relative to other domains, including language, it is holding up relatively a lot better. And so, what can we take from this? And I think one thing we can take from it is that maybe we should be using more non-verbal cues. So we can probably work around the issues of language using these non-verbal material, and also tasks that doesn't involve memory, language. So things like jigsaw puzzles, art, photography. These might in fact be hobbies that people with primary progressive aphasia might enjoy because it isn't as taxing on them. Now, of course, I'm not suggesting that if someone didn't enjoy art or photography to start off with, that you should force that upon them. But see how you go. I'm going to move on. I've presented you with some graphs. If you want to learn more about this, then this is a paper which includes those graphs and a lot more information. Happy to email this to you later. So moving away from cognition, what about aspects of behavior, mood, and function over time? So to look at these things, our group administers this questionnaire called the CBI. And for you people in the room, you may also be very familiar with this questionnaire, as we give this base essentially to our caregivers, so the family member, the spouse, basically every time that a person will come into the clinic. Again, this means that we have a lot of data, and the data we've collected for a very long period of time. In this instance, higher scores on this means frequent, so daily, whereas lower scores here mean never, or maybe once a month. Like with my other graph, I'll convert this to percentage scores. This means that scores will be out of 100. So again, high means frequent, 0 means not frequent. Okay, so I thought I'd share off with this the mood subdomain of this questionnaire. So mood on this questionnaire, it refers to things such as feeling sad, teary, agitated, or irritable. For this graph, I've also included 66 healthy controls in the graph. So our controls, these are people from the community who have graciously come in to provide us with their data points. These people, they don't have a dementia and such. And we can see that they're represented here by that red line. So if we compare our PPA lines to the red line, encouragingly, there's not too much difference between the PPA lines, both at baseline and over time, compared to the controls. Yeah, it doesn't seem to be going in much of a direction, although maybe a slight incline for two groups. Yeah. If we move across to sleep, so the sleep domain here, it actually only refers to two items, or we only ask 2 questions. The first is whether sleep is disturbed at night, and the second is whether the person is having more cat naps or sleeping during the day. And so when we combine these 2 questions together, I think we can see that that there is increasing issues or changes to do with sleep. This, for me, is a super fascinating topic, and I think it's one which I can't think of any project which has looked at sleep in primary progressive aphasia. I realize that this includes both daytime and nighttime, but if it is in fact nighttime sleep that is the issue, there are interventions, there are ways that we can improve sleep, including, better sleep routine and better sleep hygiene, and even exploring things such as, weighted blankets, seeing if that works. I'm not too sure. If you have any feedback on this, then feel free to talk to me after. For this final graph on this slide, we can see that keeping motivated over time is a bit of a problem for our patients. Motivation here relates to showing interest in hobbies, and keeping motivated to see friends outside the family. And so this is, of course, what Kristen had been speaking of. And so my data, which uses a different measure to what the data that Kristen used, is showing the same thing, just in a different type of way. Now, while this may seem confronting, I do think, like Christina said, the positive story is that now that we know about these things, these were really relatively underexplored. Motivation, it isn't fixed, it can be manipulated. And so people like occupational therapists and psychologists can certainly work in this area to improve motivation in our people. Unfortunately, it appears that looking after oneself can get a bit trickier over time. Self-care here relates to basic activities of daily living, such as grooming and dressing, whereas everyday skills relates to somewhat more complicated skill sets, such as paying the bills or using electrical appliances. In both instances, these increasing difficulties, they could be due to a multitude of factors, including problems with language and communication. Two final graphs that I wanted to show was that of abnormal behaviors and eating habits. So abnormal behaviors for this index here refers to things like acting impulsively, being a bit uncooperative, and sometimes being a bit socially embarrassing. And while all groups show changes on this domain over time, I think we can agree that the semantic group show a little more changes relative to the other groups. So again, this sort of fits well with the research that Fiona had spoken of before. Finally, it's interesting that some changes can occur over time with eating. So again, for this one, eating, it can refer to things such as developing an increased appetite, getting a bit fixed on eating times and food items. And interestingly, for our semantic dementia patients, we know that they do very much develop, or some people within this group can develop a preference for sweet foods. There's a few things that are going on here, which our group explores in a lot of detail, which, again, I'm happy to discuss later. Importantly, a main point I want to make is that while these changes are interesting and relevant, they are very much subordinate to the language problems that are experienced by our people with primary progressive aphasia. This is the exact same data, but presented just a bit differently. Okay, so for these bar charts, you may want to draw your eye on a particular group of interest to you. This is not so much interested in what the start point is for a person when they come into the clinic, but rather it's interested in what the annual rate of change over time is across those CBIS subdomains. So these graphs, they could be important for someone who has recently been diagnosed with PPA, the Frontier Clinic, and they want to know what will be the biggest change that might occur for me or for that person over the next 12 to 24 months. And so for all PPA groups, what these charts are telling us is that everyday skills, self-care, and motivation are the three biggest change points that would occur for someone after the point of diagnosis. After these three, the the subdomains vary according to the different PPA subtype. And again, this is so important, and it very much re-stresses the point that arriving at an accurate diagnosis is so important so that we can best manage and care for that person over time. Before moving on, I wanted to again emphasize how each person's story is different. And this is why clinicians find it so difficult to give definitive answers to questions about the future. So this is real data of a non-fluent patient group on their mood scores over time. So you can see that each person, they jump around quite a lot over the course of the disease, and not everyone follows the same pattern. So to bring this point home, we can see that for some patients, they start off quite high in their mood disturbance, but over time they improve. For another person, their mood score starts off quite low, but then gets increasingly higher. And then we've got someone down the bottom who over pretty much 6 years of observation have reported no change or no indication of mood problems at all. Remind me at the end to talk to you about computer learning, because I think this is an important point, and I don't want to say sort of that we don't know, and so we're not looking for ways to be able to predict things in the future. Why don't I talk about it now? So, so as a clinician, this is so frustrating, and I think we should be doing better. And so one project that we are looking to do, and this is not just for PPAs, but across all the dementia groups, is because we have an absolute sort of, it's a monster data set that we have, but we have been ambitious in cleaning that data in a particular way that we've engaged with a data digital analytics company. It's based here in Australia, but they are, top of their game in things like computer learning and artificial intelligence. And we hope to build clinical tools that, depending on how much information you can provide for an individual patient, it will be able to predict certain aspects such as functional decline, cognitive decline, and this will be super helpful because it will mean it could be relevant for things like clinical drug trials to see if we can change that prediction for that person. And it's also going to be super helpful for our allied health people so that we can better prepare to know things like when someone might need to go into residential care, or they might need allied health care in a more sort of with increasingness. Okay, lastly, again, I've given you lots of information. This all comes from a paper that we published last year. There's a lot more information here, so feel free to ask me to email this to you. Final topic I wanted to discuss is that of the relationship between what the cognition scores that people score in our clinic and that of the how they are coping in the home and within the community. Now, I've been exploring this topic for a few years, and answering this question has been really tricky. So the main message that I want to convey here is that while there is a relationship between performance on language and cognitive tests and their everyday and self-care at home, everyday skills and self-care at home, there's quite a lot of variability across individuals living with PPA. And so I was frustrated with this data, but I've now come to understand or realize that actually, I think what might be occurring here is that each person's individual home setup is so different. So you might have someone who has a lot of responsibilities during the day. They need to get up really early, milk the cows, feed the chickens, and even just to see a neighbor would involve driving long distances in a car. But for another person, they might be living in a pretty well-maintained townhouse within walking distance of the dentist, the GP, and the supermarket. And so the perceived level of independence is quite different amongst these two people, even though they might, in fact, score the same on our cognition scores. And so the positive out of this is that actually functional capacity is not just how well someone performs on these tests, but we can be proactive in improving the home setup and daily routines to ensure that that person lives more independently for longer. It's a topic that I am continuing to research, but that's a message that I want to convey here today. With that, I will end, and I'm happy to take any questions.